Hello everyone. Today we will discuss alpha fetoprotein in 5-mark short note series. What is alpha fetoprotein? It is a fetal glycoprotein. It is produced by yolk sac and liver. Clinical uses are it is extensively used in antenatal screening and oncology. So what is the structure? Alpha fetoprotein is a glycoprotein belonging to the albuminoid family and it has a molecular weight of 70 kilodaltons and a carbohydrate content of approximately 3%, and it is synthesized as a single polypeptide chain, and it is structurally related to albumin, vitamin D protein, vitamin D binding protein, and alpha albumin. AFP has multiple binding sites and can transport substances such as fatty acid, bilirubin, steroids, copper, retinoids. This binding property is crucial for fetal development, where AFP performs functions that adult albumin later takes over. So, coming to the sites of synthesis. So, it is synthesized in yolk sac and it is the main source during early embryonic life. Later, this function is taken over by fetal liver and becomes dominant source by 12 to 14 weeks of gestation, and also fetal gastrointestinal tract, and it also contributes in small amounts. After birth, AFP levels falls very rapidly as the liver switches to produce albumin. By 8 to 12 months in infantile period, the adult levels are reached. Coming to the physiology, what is the role of alpha fetoprotein? Main role is it maintains the oncotic pressure, where AFP acts like albumin and later helps in fluid balance in fetal circulation. And the transport functions include it transport bilirubin, free fatty acids, steroid hormones, heavy metals, and thyroxine like molecules. This ensures fetus receives essential molecules without any toxic accumulation. Coming to immunomodulation property, AFP may prevent the mother's immune system from recognizing and rejecting the fetus. It suppresses certain lymphocyte functions, contributing to immune tolerance in pregnancy. Regulation of cell growth. Experimental study shows AFP interacts with estrogen receptor pathways and growth promoting signals. This has implications in cancer biology, explaining why AFP reappears in embryonic tissues and transforming into malignant ones, where it can be used as a tumor marker. So in pregnancy, it is present in the range of 10 to 150 nanogram per deciliter. Maternal serum by 32 weeks up to 250 nanogram per deciliter, though it might vary. In the neonate at birth, it is in tens and thousands of range. It is 40,000 nanogram per deciliter or maybe more. At 4 months, much lower, but there will be a steady decline. And in infancy, it reaches the adult level of 10 to 15 nanogram per deciliter. The first use is antenatal screening. The second one is as a tumor marker in adults, and it is also associated with other liver disorders and monitoring and prognosis of those liver disorders. Coming to antenatal serum. So when there is a low AFP in the maternal serum, it may be due to Down syndrome, Edwards syndrome, or overestimated gestational age. The causes of raised AFP maternal serum include neural tube defects like anencephaly, open spina bifida, or abdominal wall defects like gastroschisis or omphalocele, multiple gestation, fetal demise, congenital nephrosis, placental aberration or defects, or underestimated gestational age. Coming to tumor markers in adults. AFP rises in cancers and resemble embryonic or fetal tissues. Like in case of hepatocellular carcinoma, AFP rises up to the level of 400 nanogram per deciliter, which is strongly suggestive of it. And its early detection in high risk groups like hepatitis B virus or cirrhosis. It aids in the diagnosis. It helpful in monitoring response to therapy, detecting recurrence. In HCC, the liver regresses to an embryonic phenotype, regaining AFP production. Coming to germ cell tumors. So, yolk sac tumor, non-seminomatous testicular tumor, mixed germ cell tumor, and AFP helps differentiate a seminoma in where AFP is not elevated and non between the seminomatous tumor and non-seminomatous tumor, wherein AFP will be elevated in the non-seminomatous version. In childhood malignancies like hepatoblastoma or certain embryonic tumor, AFP is valuable in those pediatric oncology for both diagnosis as well as follow-up. Coming to the other liver disorders, there will be mild to moderate liver elevation occurs in viral hepatitis, cirrhosis, liver regeneration, alcoholic liver disease. AFP has a half-life of 5 to 7 days and help assess whether tumor removal was complete. Coming to the monitoring and prognosis, a falling AFP after tumor resection is a good response, whereas a rising AFP indicates recurrence or progression. Persistently very high levels of AFP can also lead to suspecting hepatoblastoma. Coming to diagnostics, we have to measure AFP at 15 to 20 weeks and repeat it if it is abnormal and confirm using level 2 ultrasound or amniocentesis. In oncology setting, it is combined with beta HCG, LDH, and ultrasound CT MRI used as a part of tumor staging systems. Coming to the limitations, it is not very cancer specific, can rise in benign liver disease also, not elevated in all the cases of hepatocellular carcinoma, wherein 30 to 40% have normal AFP, leading to false negative cases. False positive may also create anxiety during pregnancy, need gestational age accuracy, must be interpreted with other markers and clinical findings is not a standalone diagnostic marker. So to summarize, AFP is a fetal glycoprotein functioning as a fetal albumin produced in the yolk sac initially up to 12 weeks followed and the function is taken over by fetal liver thereafter and also some part is played by gastrointestinal tract. It contributes to immune tolerance during pregnancy and it maintains oncotic pressure, transport bilirubin, fatty acids as well as hormones. AFP levels are very high in the fetus, crosses the placenta into maternal blood, and they fall very rapidly after the birth. And it is an essential second trimester screening tool marker where elevated levels suggest neural tube defects and low level indicates chromosomal disorder. In case of adults, it acts as a tumor marker for hepatocellular carcinoma, yolk sac tumor, mixed germ cell tumor, and it is also useful in diagnosis, prognosis, and surveillance of these three cancers. It is most important biomarker in AN screening and oncology. So I hope you learned from this. Thank you for watching the video.